Today we will be dealing with renal tumors. Renal tumors, you know, the tumors of the kidney, which can be benign or malignant. The usual benign neoplasms or tumors are the oncocytomas, angiomyolipomas, adenomas, and reninomas. Reninomas are otherwise known as the juxtaglomerular cell tumors. There is one more thing in this which can be included, that is the renal cyst, which exactly is not a tumor but more of a fluid-filled neoplasia. Uh, Here, a space-occupying lesion, that would be a better term for the renal cyst. So I will say, because it is very common, probably we should know more about renal cysts. I will detail on that later on. The malignant neoplasms are, the most common one is the renal cell carcinoma. Then the urothelial tumors. Urothelial tumors are various types, which we will tell you later. Then sarcomas, Wim's tumor, which is more of a childhood tumor. Then lymphomas and metastasis from different organs. The most important thing in the management of the renal tumors are the differentiation between the malignant cells and the benign, which can usually done either with radiologically or clinically, and which can most of the time can be very challenging. You know, women are most likely to have benign histologic types than malignant ones. Now, coming to the benign renal cyst. They can be a simple cyst, which is otherwise known as the cortical cyst, and they are the most common benign renal lesions. Almost every other person might be having a renal cyst, either single or multiple. And more than 70% are, if you take the asymptomatic renal masses, almost 70% are a renal cyst, a simple cyst. And the prevalence actually increases with age. Almost if the patient's age is about 50, past the middle age, almost 50% of them will be having a renal cyst. That is, it is such a common problem. Now, a cyst has certain radiological characteristics, which can be either by sonologically or by a CT scan. You can see a very smooth cyst wall, which are very thin usually, and it will have a round or oval shape, and there won't be any internal echoes. If you take an ultrasound, you won't see any internal echoes within that fluid content within that cyst. If you take a CT scan, there won't be any density within the cyst, and there won't be any calcifications either in the cyst wall or within the cyst, and there will not be any solid areas. There won't be any significant thickening of the walls. There are no solid areas. So these are the characteristic features of a simple cyst or a cortical cyst. So these things usually only when it becomes huge, very large, only then it can, or when it becomes a complicated, that is either by having a hemorrhage into the cyst or having an infection in the cyst, only then it usually becomes symptomatic. Otherwise, it is more of a asymptomatic problem. A Bosniak is a person who has classified this cyst in various types. It is a very important classification, which you should know, and is a type 1 cyst is a simple cyst. That is, all the features I already told you, like a thin walled, no thickening, no calcification, and very smooth, regular features with no internal density or echogenicity within the cyst. We call it as a Bosniak type 1, which is a simple cyst. And there is absolutely no chance of malignancy in such cysts, which doesn't require any management in most of the cases. Whereas in type 2, there are some features which might be prominent, like some kind of a septa within the cyst wall. And these septa sometimes there will be some calcifications, some very thin calcifications might be seen. They are called type 2 cysts. Type 2 cysts. And the chance of malignancy again in these type 2 cysts are very, very, very low, maybe less than 5% the maximum. And both these type 1 and type 2 cysts require no intervention. They just need to be observed. Type 1 you can just ignore, and type 2 maybe you follow up. That's all. It doesn't require any intervention. But in a type 3 cyst, all the features I said earlier, that is the septal, the thickness of the septa, the calcification, and some solid areas, and the number of septae, all these features are more pronounced in type 3. But the problem is, when it becomes type 3, the chance of it being a malignancy is almost half the time. So it is 50% of the got chance of becoming a malignant lesion. So it warrants surgery in that case. So type 3 has got a surgical risk. I mean, there's a chance malignancy risk is there. So, but almost 50% chance of malignancy, but requires excision. Whereas in type 4, which is actually a malignant cyst with regeneration, we have a very thick wall, solid areas, and even have contrast enhancement by the CT scan, and the chance of being a malignancy is almost 100%, and again it requires an nephrectomy. So these are the 4 types of cysts as per the Bosnian classification: type 1, type 2, type 3, and type 4. This is you can see that the type of cyst which a very smooth bordered thin wall cyst with very free echogenic, no echogenicity within the fluid, and maybe a very thin septa might be seen in that part of the, so it could be, we can call it as a type 2 cyst rather than a type 1 cyst here. And the management, all the type 1 cysts doesn't require any management. Sometimes if it is huge, very huge, maybe you can have a percutaneous drainage or kind of a sclerosis with a 95% alcohol, and maybe you can de-roof it by laparoscopically. Generally, not much of a management is required. Neither, and the type 3 and type 4, it has to be dealt as a malignancy. Another benign tumor is oncocytomas, which is a not a very common tumor. Only 3% or 7% of all solid renal masses, and it is derived from the distal renal tubules. The importance of oncocytoma is that it almost mimics a renal cell carcinoma. It looks exactly like a renal cell carcinoma. That is the importance of this. Very difficult to differentiate an oncocytoma from a renal cell carcinoma. And either by clinically or radiologically, it's very difficult. If you take a CT scan, but you might be, if you're lucky, you might see a central stellate scar, a star-shaped scar can be seen in the CT scan. And if you take an angiography, you can see a spoke wheel pattern of the feeding arteries, which is very classical of oncocytomas. But having said that, I must tell you that if you see a mass lesion with a strong suspicion of oncocytoma, and you can even say this may not be renal cell carcinoma, but still the option for you is just like a renal cell carcinoma. And if at the end of the surgery, even a nephrectomy, and the histopathology says it is oncocytoma, you can tell the patients you are lucky that it is not a malignancy. But you cannot say you don't require a surgery with a clinical or a radiological diagnosis of oncocytoma. You have to go for surgery, and but you are safe with the diagnosis comes to oncocytoma, because there is no chance of metastasis or any further follow-up. Nothing is required. And this is the one classical oncocytoma. You can see that central scar, which is appreciable even in the CT scan. Then comes the angiomyolipomas. Angiomyolipoma is an periendothelial tumors called PEComas. PEComas they are called, and it's a benign neoplasm consisting of adipose tissue, the fat tissue, and smooth vessels and thick-walled vessels, blood vessels. It was originally identified by Fisher in 1911, and Morgan named it as in 1951. Etiologically, it is usually associated with tuberous sclerosis, which is it's a syndrome involving having multiple vascular lesions in the body. You can have classically because of the intracerebral lesions, you can have a low intelligence, seizures, epilepsy. Then you can have classical skin findings on the face, in the or the face in the something like a butterflies area, in the butterfly area around the nose, adenoma sebaceum, which is very classical of tuberous sclerosis. So tuberous sclerosis, otherwise known as epiloia. Epiloia means epilepsy, low intelligence, and adenoma sebaceum. Other name is a bone-wilt disease, same as tuberous sclerosis. But all these, the tuberculosis, it has got a classical association to have a multiple angiomyolopamas bilaterally in the kidneys. An ultrasound, you can see a well circumscribed, highly echogenic lesion because of the fat content. Fat is highly echogenic. So because of the fat, the ultrasound will be highly echogenic. And the CT scan, it will be very low density because of the fat content. It can be even minus level, minus 20 Hounsfield units is the usual thing. So whenever you see a very low density CT scan mass, that means the presence of fat, and a mass in the kidney with fat is usually a angiomyolipoma. And this is one classical ultrasound picture of the angiomyolipoma. You can see the hyperechoic area, the arrow shows that hyperechogenic lesions. And angiogram shows an aneurysmal dilatation with more than almost half of the patients, and sunburst appearance and onion peel appearance are very classical in angiomyolopamas. If you take an MRI, a fat suppressed images of MRI may be helpful in difficult cases. This is one such picture. And this is the histopathology and the angiogram and CT scan of the angiomyolipoma. You can see the very large fat cells, which is empty cells, it appears like, and this is the angiogram of the large angiomyolipoma. Now, the distinction between the angiomyolipoma and the renal cell carcinoma is very important, and the presence of fat itself is the most important finding. It is almost diagnostic of angiomyolipoma, but sometimes the renal cell carcinoma also can have fat, though it is very, very rare. Another of this is calcification. Calcification absolutely not absent in angiomyolipoma, but it is very common with the renal cell carcinoma. And a typical acoustic shadowing in ultrasound is classical of angiomyolipoma because of the presence of fat, which is not seen in renal cell carcinoma. And you can have aneurysmal dilatations in angio, which is not seen in renal cell carcinomas. So an asymptomatic, smaller angiomyolopamas, by convention, the tumor less than 4 centimeter, it need to be observed expectantly. Just need to follow up, and maybe repeated evaluation every 6 or 12 months is what required. And if it is larger than that, or if it is causing a bleeding complications, it might require a surgery or an intervention, either by an angiogram and embolization of the tumor, or going for a partial nephrectomy. If it is a multiple and almost involving almost all the kidneys, might require a nephrectomy as well. Now coming to the renal cell carcinomas, it is otherwise known as the hypernephroma or the Gravitz tumor, or the internist tumor, because it can have a varied presentations. That's like it can present in a internal medicine department with very different types of presentation. That is why it is known as the internist tumor. Almost 75% of all renal parenchyma tumor, it is a renal cell carcinoma, and 3% of all cancers in the of humans is a renal cell carcinoma, and it is 85% of the adult renal tumor is a renal cell carcinoma. It is more common in the males. It usually occurs in 6th or 7th decade of the presentation, but nowadays it is more common in the younger age because we diagnose this with ultrasound, because ultrasound has become very common. For every other reason, we might do an ultrasound. So the chance of picking up a renal cell carcinoma early and a younger age group is quite common. Etiologically, the related factors are smoking, obesity, and hypertension. And majority of the cases of renal cell carcinoma, they are sporadic. Only 4% are familial, 4 out of 100, and they're usually associated with the von Hippel-Lindau syndrome, hereditary papillary renal carcinomas, and hereditary leiomyomatosis. It is usually of proximal tubular epithelium of is the origin of the malignancy. And a word about the von Hippel-Lindau disease. It's an autosomal dominant associated with 3p chromosome. And the major manifestations are due to renal cell carcinoma, pheochromocytoma, retinal angiomas, hemangiomoblastomas of the brainstem, cerebellum, and spinal cord. It's a very early age onset of malignancy, and bilateral and multifocal involvement are quite common here. Pathologically, most anesthesias are round or ovoid, circumscribed by pseudocapsule and compressed parenchyma and fibrous tissues. Pseudocapsule is quite common in the renal cell carcinomas. Most renal cell carcinomas are not grossly infiltrative, with a notable exception being a collecting duct renal cell carcinoma, where it can have high chance of infiltrations. This is a nephrectomy specimen, which you can see the renal cell carcinoma with a solitary, spherical, well-circumscribed mass. And if you cut it, again, you can see that it's a well-circumscribed, but the characteristic feature is the pseudocapsule and the variegated appearance. And you can see the pseudocapsule because of the compressed parenchyma and the fibrous tissue. And this is another picture. You can see the cystic changes within the kidney. There's a lower pole of the kidney. And the cystic changes are usually have a better prognosis. You can even see a calcification, stipple calcification, or a plaque-like calcification seen here. Almost 1 out of 5 patients will have this. And here you can see the areas of hemorrhage and necrosis, which is also very common. And the clear cell carcinomas are the more common variety. Almost 70 to 80% are the clear cell types. This is the histopathology of this type. And the second common is the papillary or the chromophilic tumor, which is renal cell carcinoma is of 10 to 15%. And in papillary carcinoma, the multicentricity is very high. Another type is the chromophobe renal cell carcinoma. Almost 3 to 5% are chromophobe type, and the characteristic feature is the perinuclear halo, something like a plant cell appearance. There are numerous microvesicles, and they stain positively for Hale's colloidal ion stain. The other rarer varieties are the collecting duct or Bellini duct carcinoma, the renal medullary carcinoma, which is exclusively seen in the sickle cell trait, and sarcomatoid variants are not usually now included as a renal cell carcinoma. It is considered a separate renal sarcoma itself. And regarding the aggressiveness of the tumor, there is a nuclear grading is available, which is by the Fewman's classification, which is based on the nuclear size and the nuclear outline, whether it is round or irregular, and the presence of nucleoli. So these are the 3 factors taken to have a grading, or the Fewman. It's grade 1, 2, 3, and 4, depending on the nuclear size, nuclear outline, and nucleoli, the presence of nucleoli. The clinical presentation of renal cell carcinoma is by the flank pain, hematuria, and palpable abdominal mass. But most of them, as I told you earlier, because of the scans are very quite common now, most of them are discovered incidentally in the asymptomatic phase. And this classical feature of all these 3 features, like a flank pain, hematuria, and mass, is a triad, and which is usually only seen in a very late presentation, almost probably in 10% of the cases. And in such a situation, almost of them will have an advanced disease with metastasis at the time of presentation. Very rarely you can have a scrotal varicocele because of the obstruction of the gonadal veins by the renal vein involvement of the tumor thrombus. You can have a vena cava involvement, even it can extend up to the atria. It can produce ascites, hepatic dysfunction. Then local extension can be there with the liver, pancreas, and colon. And it can metastasize to lungs, lymph nodes, bones, and liver, brain, adrenal, even contralateral kidney. It can go. One characteristic feature of renal cell carcinoma, that is why I told you it is called as the internist tumor, is the presence of paraneoplastic syndromes. Paraneoplastic syndromes is a very characteristic of renal cell carcinoma. Their features are an increased ESR, hypertension, anemias, weight loss, fever, an abnormal liver function test. This is not due to metastasis. Abnormal liver function, and it is non-metastatic. That is known as the Stauffer syndrome, polycythemia, neuromyopathies, amyloidosis, hypercalcemia. Very rare, but these are very characteristic of renal cell carcinomas. Regarding the staging, this is the old Robson's staging, where stage 1 tumor is within the capsule, and stage 2 tumor invasion into the perinephric fat but within the geroid fascia. Type 3, it is outside the geroid fascia, involving the regional lymph nodes or into the renal vein, or the vena cava. And the stage 4, adjacent organs and distant metastasis. There is a TNM staging, whereas T1 is a tumor less than 7 centimeter, and T2 is a tumor more than 7 centimeter but limited to the kidneys. T3, tumor extends to the major veins or the adrenal gland or the perinephric tissues, which can be T3A is the adrenal gland involvement or the perinephric tissues, but not beyond geroid fascia. T3B is involvement of the renal vein or vena cava below the diaphragm. T3C is tumor extending to the vena cava above diaphragm, and T4 tumor inverts beyond geroid fascia. So N0 is the regional lymph nodes, no regional lymph nodes. N1, any metastasis in the regional lymph nodes. And distant metastasis is M0 and M1. Stage 1 is T1, that is 7 centimeter, less than 7 centimeter, N0, M0. Stage 2 is more than 7 centimeter within the capsule, N0, M0. Stage 3, it can be a T3 tumor or an N1 tumor. T3, N1, or T3 N0 M0, or any T with N1 M0. Stage 4 is T4 N0 M0, or any T or any N with M1. The pre-surgically, you have to have a imaging with a clear diagnosis, and a CT scan probably with excellent diagnostic options. MRI is done whenever there is a renal vein involvement or a inferior vena cava involvement. You have to do a MRI as well. And a CT scan, you can see the lesion heterogeneous with a high Hornsfield unit, almost equal to that of renal parenchyma. You can see here. And in MRI, as I told you, in a locally advanced disease, when there is an obliteration of fat planes and superior for any IVC involvement, and if you are not able to take a CT scan, this is an MRI picture. You can see that tumor, large tumor involving the outer aspect of the kidney. And bone scan, if there is a suspicion of a bone metastasis, chest X-ray. Renal angiography, if you are planning a nephron sparing approach, a partial nephrectomy, you may do an angiogram. And if you have an upper pole tumor with an adrenal involved possibility, you can do an angiogram as well. And this is the renal angiogram showing renal cell carcinomas. It's a very vascular tumor. Putting in a needle into the tumor is very, very, very controversial. You should not do most of the times. It's very questionable, because by putting the needle, you can actually upstage the disease, because the tumor stage is dependent on whether it is involved in the capsule, geroid fascia, or the outside the geroid fascia. So when you're putting in the needle, there is always a chance of seedling of the tumor to go outside. So a T1 tumor becomes a T4. So it's an upstaging is very much likely. So you should never put in a needle in a renal mass unless there are indications for it. If you are in an abscess, possibility of abscess, yes, you have to put a needle. Or if it is already metastasized tumor, that is a metastatic tumor, then you are not going to upstage it at all. You may do put in a given patella. Or in the other situation is that when you are strongly suspecting a lymphoma, that is, there are multiple lymph nodes in the totally non-local regional lymph nodes, like iliac lymph nodes, axillary lymph nodes. Multiple lymph nodes are there all over there. There's a chance of this tumor, this renal mass to be a lymphoma. You can put in a needle for the diagnosis, because you need only chemotherapy for that. And involvement of the veins, that is the renal veins and the inferior vena cava, is not a poor prognosis. You can remove that completely. You can just pull it out, opening of the vena cava, you can do it. So poor outcome in a renal cell carcinoma is mainly when the presence of weight loss, a symptomatic presentation, there's a triad, anemia, hypercalcemia, thrombocytosis, increased ESR, and the paraneoplastic signs, and the high pathologic grade, nuclear grade, the Fuhrman grade. The size of the tumor is so huge, that is a T3 beyond T1 tumor, and the histological subtypes, lymph node involvement, performance standards all have an influence on the outcome of the disease. The treatment is surgery, and radical nephrectomy is the gold standard. Localized renal cell carcinoma, the treatment is radical nephrectomy, which involves early ligation. The first thing the dissection is done outside the aorta fascia. That is, you have to go for the renal artery and vein and use doubly ligated and divided. And generally, the classical teaching is that you have to remove the ipsilateral adrenal gland and complete a regional lymph nodenectomy from the crus of the diaphragm to the aortic bifurcation. But nowadays, we don't do that. We say what we do is there is no need to do an adrenal gland removal unless you definitely the adrenal gland is also involved on an apropos tumor. There's a chance of adrenal being involved. Only then you need to remove the adrenal gland. So, and the lymphadenectomy is not being done because whether the lymph nodes are present or not, if it is already involved, the prognosis is very bad. If it is not involved, you are it doesn't make, if you do a renal lymphadenectomy, even if it is done, it doesn't make the difference in prognosis after a radical nephrectomy. So it is also not being done these days. So the major change that has happened in the radical nephrectomy nowadays is that we don't routinely remove adrenals and we don't routinely remove lymph nodes unless they are obviously visibly involved. Then the surgical approach, there are various approaches. Transperitoneal to assess the intra-abdominal, and it is the extended subcostal or a bilateral subcostal, a thoracoabdominal approach, an extraperitoneal flank incision also. Then these are the approaches: the subcostal and the bilateral subcostal, midline, and the thoracoabdominal. All approaches are possible, even laparoscopically. You can remove it, especially with a. But nowadays, even large tumors are also being removed by laparoscopically by experts, and transperitoneal. Some people even do retroperitoneal by laparoscopically, and the results are pretty the same, comparable. A nephron sparing surgery is that it has come off late. That you need not do the entire kidney, need not be removed. Only the part of the kidney, the tumor, as well as the portion around it is good enough. If the margin must be negative, that's all. As long as the margin is negative, you get a good result with that kind of a removal. So, but you require a three-dimensional CT reconstruction images before that, before the proceeding with it, and also require a renal angiogram. And success rate is excellent. Definitely, it is very much advisable in a small renal tumors. This is what you do for a partial nephrectomies, an upper pole nephrectomy. You close the pelvic calcium system, and even the parenchyma is closed like this. Then you can have a wedge resection like this. And there are, if the surgery is not feasible, maybe go for a cryo surgery or a radiofrequency ablation, but not only for very elderly, unfit patients with a very small tumor, very limited indications. In case of vena cava invasion, there are 4 levels. Level 1, that is the tumor is involving the renal vein, but just up to the ostium of the renal vein. In a level 2, it is entering the inferior vena cava, but not below the level of the lower aspect of the liver. And level 3, it is below the diaphragm, but intrahepatic portion of the inferior vena cava also is involved. And level 4, it is extending above the diaphragm, even into the right atrium. These are 4 levels of surgery. 4 levels of vena cava involvement. It's vena cava thrombectomy. This is a picture of the vena cava thrombectomy. Usually gives very good results if the thrombectomy can be done completely. In case of metastatic disease, almost 1/3 will have a metastasis. Only symptomatic nephrectomy. Palliative nephrectomy, you can call it. And the results are very, very poor because surgery has absolutely no role here. And usually chemotherapy as well as any other therapy usually doesn't have much of a choice. The prognosis is pretty bad. Now coming to the urothelial tumors of the kidney, they are usually transitial carcinomas. Sometimes can be a squamous cell carcinoma or adenocarcinomas. Adenocarcinoma is usually either with the urachal elements within the kidney, usually seen the fundus of the bladder. And the urothelial tumors usually involves the renal pelvis and calyces, usually present with hematuria or clot colic. And ultrasonogram is an adenocarcinoma of the kidney. I just regarding the urachal elements, I was talking about the bladder tumors, not about the kidneys. I need to please correct that. An ultrasonogram is a very excellent method of diagnosis in this. A CT urogram, MR urograms, all can give you an excellent diagnosis of the urothelial tumors. Not very common, but when the elderly patient with coming with hematuria, colics, you should think of a urothelial tumors of the kidney. And the treatment here is nephrectomy, plus the ureter also has to be removed, because there is a when there's a urothelial tumors, even the entire ureter has the potential to have a recurrence. So the ureter also is, but because once the kidney is removed, the ureter is not useful. So the entire ureter is also taken with, even with a cuff of bladder. So at nephrouretrectomy is the treatment of choice in urothelial tumors. Thank you.